In this presentation, the techniques for closed reduction and reamed intramedullary nailing of a tibia shaft fracture will be demonstrated using the Expert Tibial Nail, or ETN. Upon completion of this exercise, you should be able to state the clinical indications and contraindications, describe the correct patient positioning, identify the appropriate reduction techniques, recognize the surgical approach and entry point, and perform reamed intramedullary nailing using the ETN. The Expert Tibial Nail is indicated for diaphyseal fractures of the tibia as well as for metaphyseal and certain intra-articular fractures of the tibial head and the pilon tibiale. These include 4-1, A2, A3, 4-2, ABC, 4-3, A1, A2, A3, and combinations of these fractures. Contraindications include a deformed medullary canal, for example resulting from prior fracture or previously inserted hardware, patients where the risks of surgery and anesthesia exceed the benefits, medullary infection, proximal or distal fractures which compromise intramedullary nail use, such as intra-articular fractures, lack of appropriate nail size and configuration. For simple shaft fractures, 2 proximal and 2 distal mediolateral locking screws are normally sufficient to stabilize the fracture. With fractures involving the proximal component, optimal stabilization of the proximal fragment is ensured with 3 locking screws that use the proximal oblique locking options. The distal segment can be stabilized using the 2 mediolateral locking options. The stability of the distal fragment can be enhanced with the use of a 3rd locking screw in the AP hole. With fractures involving the distal component, the use of 4 distal locking screws is sometimes necessary to achieve stabilization of the distal fragment. However, in many cases, 3 locking screws placed using the most distal locking options are sufficient. The patient is positioned supine on a radiolucent table with the knee flexed from at least 90 and up to 110 degrees. The image intensifier is positioned so that visualization of the tibia, including the articular surface proximally and distally, is possible in both the AP and lateral views. Reduction is an essential part of intramedullary nailing. The fracture must be reduced to allow both guide wire placement during reaming and nail insertion. It is important that length, angulation, and rotation are all restored. Additional correction of alignment may be needed even after guide wire insertion to avoid deformity. This should be performed before reaming and nail insertion. Reduction is usually more challenging with proximal and distal fractures as well as with cases of delayed treatment. Sometimes only mild traction and rotational adjustment are required. Percutaneous reduction aids such as pointed reduction forceps, Schunz screws, or a ball spike pusher may allow reduction without opening the fracture. With other fractures, open reduction may be necessary. Depending on the patient positioning and type of OR table, 1 or 2 people may be required to perform manual traction. The illustration shows a triangular radiolucent supporting frame with padding over the top placed proximal to the popliteal fossa. It provides counter traction when the fracture is lengthened with distal traction. For patients positioned on a radiolucent table without knee support, 1 person holds the leg and the other pulls the leg distally. The reduction is controlled during traction by palpating the tibial crest and the anteromedial surface. The required nail length must be confirmed after fracture reduction. The radiographic ruler for Expert Tibial Nail is recommended to confirm the nail length and diameter. To do this, the C-arm is positioned for an AP view of the distal tibia. With long forceps, the ruler is held along the leg parallel to and at the same time level with the tibia. The ruler is adjusted until the distal tip is at the level of the physeal scar or the desired nail insertion depth and the skin is marked at that site. The C-arm is repositioned to the proximal tibia, the distal end of the ruler is relocated to the skin mark, and an AP image is taken of the proximal tibia. The nail length is read directly from the ruler image, and the measurement at or just below the level of the anterior edge of the tibial plateau is used. The C-arm is then positioned for an AP or lateral view of the tibia at the level of the isthmus. The ruler is held over the tibia so that the diameter gauge is centered over the narrowest part of the medullary canal. The diameter measurement is read from the circular indicator that fills the canal. The entry point defines the optimal position of the nail in the intramedullary canal. This is especially important to prevent fragment displacement with fractures located proximally or in the distal third. In the AP view, the entry point is in line with the central axis of the intramedullary canal, about 3 mm medial to the tibial crest, and with the lateral tubercle of the intercondylar eminence. In the lateral view, the entry point should be located just distal to the angle between tibial plateau and anterior tibial metaphysis. To find the correct entry point, the tibial crest is identified and a guide wire is placed along it, extending proximally over the knee. The correct insertion point will be at the intersection of the guide wire with the tibial plateau. A longitudinal skin incision is made over the planned entry point. It is extended 3 to 5 centimeters proximally from the level of the tibial plateau. An incision that is too medial interferes with proper entry into the medullary canal. The incision may go either through or around the patellar tendon. It is important that it is made directly in line with the medullary canal. This may only be possible by going through the tendon, A, but if the tendon can be retracted sufficiently for direct access, this is also possible. B. Proximal tibial shaft fractures tend to develop a valgus deformity if the nail entry site is placed too medially. A more laterally placed skin incision may be needed to avoid this problem. The instruments used to insert the guide wire are the guide wire, 3.2 mm diameter, and the universal chuck with T-handle. The guide wire is secured in the chuck. The insertion point is slightly punch-marked at a 10-degree angle to the shaft axis in the lateral view. The guide wire is inserted approximately 8 to 10 centimeters and its position is checked under image intensification in the AP and lateral views. The instruments used to open the medullary canal are the cutter for tibial nail, 12.0 mm diameter, and the protection sleeve, 14.0, 12.0. The protection sleeve and the cutter are slid over the guide wire, and the medullary canal is opened to a depth of 8 to 10 centimeters. The guide wire and cutter should not touch the posterior cortex. The guide wire, cutter, and protection sleeve are removed. The instruments needed to ream the medullary canal include the Synream reaming rod, 2.5 mm diameter, the 5.0 mm flexible shaft, the medullary reamer heads, which range in size from 8.5 to 12 mm in 0.5 mm increments, the holding forceps, and the removal tool. Before reaming, the fracture reduction must be confirmed under image intensification. The reaming rod is inserted into the medullary canal to the desired insertion depth. To begin reaming, the 8.5 mm diameter reamer head is attached to the flexible shaft by inserting the tip of the shaft into the cannulation of the reamer head in the tray. The 8.5 mm reamer head can be seen to have a cutting tip. The reamer is advanced over the reaming rod with steady, moderate pressure. The reamer should not be forced and is often partially retracted to clear debris from the medullary canal. After reaming, the reamer head is withdrawn from the canal until the reamer head is visible. To prevent loss of reduction, the reaming rod is grasped and held in place using the holding forceps just above the entry point. The used reamer head can be detached from the flexible shaft using the slot in the side of the removal tool. The reaming procedure is continued, reaming in 0.5 mm increments up to a diameter of 0.5 to 1.5 mm greater than the nail diameter. Starting with the 9 mm reamer head, it can be seen that the larger-sized reamer heads do not have a cutting tip. As the nail diameter is 9.0 mm, we will ream to a diameter of 10.5 mm. The instruments used to insert the nail include the radiolucent insertion handle, the connecting screw, cannulated, short, the screwdriver, hexagonal, 8.0 mm diameter with spherical head and T-handle, the driving cap with thread, the combination wrench, 11 mm diameter, the hammer guide, the pin wrench, 4.5 mm diameter, and the combined hammer. The insertion handle should be oriented anteriorly with the tab on the handle matched to the notch on the nail. The connecting screw is placed through the insertion handle and threaded into the proximal end of the nail with the hexagonal screwdriver. After verifying that the nail is properly oriented on the insertion handle, the assembly is secured and tightened. The driving cap with thread is threaded into the insertion handle. The nail is inserted over the guide wire into the intramedullary canal. A wriggling motion can be used to advance the nail. If needed, light, controlled hammer blows can be used to seat the nail. The passage of the nail across the fracture is monitored and controlled with image intensification in two planes to avoid malalignment. The nail should be inserted until it is at or below the tibial opening. The guide wire is removed. Final nail position is confirmed in the AP and lateral views. The aiming arm is attached. For proximal locking, it is important that the aiming arm is mounted only when the nail has been completely inserted. Otherwise, the aiming arm may loosen during nail insertion. To check the proximal nail position, a guide wire 3.2 mm diameter is inserted through the hole in the aiming arm marked nail end down to the bone. The tip of the guide wire indicates the exact proximal position of the nail. The proximal position of the nail is verified under image intensification in the lateral view. It should be noted that the distance between the markings on the insertion handle is 5 mm, which corresponds to the extensions of the end caps. This feature can be used with over-insertion of the nail or for correcting the nail location within the medullary canal. If either primary compression or secondary dynamization is planned, it is recommended to over-insert the nail by more than 7 mm, which corresponds to the maximum distance between the positions in static and dynamic modes. The guide wire is removed from the aiming arm. The driving cap is unthreaded from the insertion handle. The next step is to lock the nail either distally or proximally. If the fracture was distracted, distal locking would be performed first and the aiming arm would now be removed. In this exercise, as there is no fracture, distal locking will be described but not performed, so the aiming arm remains attached for proximal locking. The nail diameter is used to determine the drill bit and locking screws that will be used to lock the nail. In this exercise, the dark blue 9.0 mm diameter nail has been inserted, so the 3.2 mm drill bit and the 4.0 mm locking screws whose dark blue color corresponds to the nail, would be used for distal locking. It is recommended to lock distally first, thus enabling the use of the backslap technique to prevent diastasis. Locking of the tibial nail is usually performed from the medial side, if possible, with the leg extended. This position helps counteract the forces exerted by the quadriceps muscle that would tend to deform the proximal fragment and also facilitates rotational control of the tibial axis before locking. The position of the nail is verified under image intensification. The reduction, correct alignment of the fragments and leg length must be confirmed before locking the nail. The C-arm is aligned with the hole in the nail closest to the fracture until a perfect circle is visible in the center of the screen. Here, the distal mediolateral hole is used. A scalpel blade is placed on the skin over the center of the hole to mark the incision point. A stab incision is made. Using the radiolucent drive under image intensification, the tip of the 3.2 mm drill bit is inserted through the incision down to the bone. The drive is angled so that the tip of the drill bit is centered over the locking hole. The drill bit should nearly fill the circle of the locking hole. The drill bit is held in this position while the hole is drilled through both cortices. Drilling is stopped immediately after both cortices have been penetrated. After confirming the correct position of the drill bit beyond the far cortex, the radiolucent drive is detached. The direct measuring device is slid over the drill bit, and the appropriate length for the locking screw is determined from the measuring device at the end of the drill bit. The appropriate length locking screw is inserted using the screwdriver star drive T25 and the holding sleeve if needed. The screw length is verified under image intensification. A second locking screw may be inserted using the same technique. 3 proximal mediolateral locking options can be targeted using the aiming arm. 2 are described in this section. Static locking option 1, marked Stat 1, corresponds to the most distal of the proximal locking holes. Static locking option 2, marked Stat 2, corresponds to the lower position of the proximal locking slot. This type of locking does not allow primary compression or secondary controlled dynamization. The instruments needed for proximal locking include the trocar 3.2 mm diameter, the drill sleeve 8.0 3.2, the protection sleeve 12.0 8.0, the 3.2 mm drill bit calibrated, the depth gauge for locking screws measuring range up to 110 mm, and the screwdriver star drive T25 self-holding. Since a 9.0 mm nail has been inserted, 2 4.0 mm diameter locking screws will be used. It should be noted that the blue color of the screws corresponds to the color of the nail, as well as the blue markings on the 3-part trocar combination and drill bit, as well as the aiming arm. The 3-part trocar combination, which consists of the protection sleeve, drill sleeve, and trocar, is assembled. It is then inserted through the hole in the aiming arm marked Stat 1, through a stab incision, down to the surface of the bone. The trocar is removed. While ensuring that the drill sleeve is pressed firmly to the near cortex, a 3.2 mm hole is drilled through both cortices until the drill bit just penetrates the far cortex. The position of the drill bit is confirmed with image intensification. The drill bit is withdrawn and the drill sleeve is removed. The depth gauge is disassembled into 2 parts, the outer sleeve and the measuring device with hook. While ensuring that the protection sleeve is pressed firmly to the bone, the measuring device is slid through it, making sure that the hook grasps the far cortex. The length of the first locking screw is determined by reading the measurement at the back end of the protection sleeve. In this case, 40 mm is measured. The 4.0 locking screw is inserted through the protection sleeve and threaded into the hole with the screwdriver star drive T25. The screw length is verified under image intensification. The tip of the locking screw should not project more than 1 to 2 mm beyond the far cortex. After the length of the screw has been verified, the screwdriver and protection sleeve are removed. The screw insertion sequence is repeated for the second mediolateral locking screw using the hole marked STAT2 in the aiming arm. In this case, a 40 mm screw is used. End caps for the ETN are available in extension lengths of 0, 5, 10 and 15 mm. In this exercise, the 0 mm end cap will be inserted using the screwdriver star drive T40. The end caps are cannulated for use over a guide wire if necessary. End caps prevent bone growth into the nail, and they extend the nail height if it has been over-inserted. The screwdriver, hexagonal 8.0 mm diameter with spherical head and T-handle, is used to loosen the connecting screw so that it can be removed together with the insertion handle and the aiming arm. To prevent cross-threading, the end cap is inserted in line with the nail axis. A counterclockwise turn can be used to thread it in the nail before clockwise turns are used to advance it and secure it. Clinically, implant removal is an optional procedure. The instruments needed include the screwdriver, star drive T40 with spherical head, cannulated, length 330 mm. The extraction screw for tibial and femoral nails, the combination wrench 11 mm diameter, the hammer guide, the pin wrench 4.5 mm diameter, the screwdriver star drive T25 self-holding, length 330 mm, and the combined hammer. The T40 star drive screwdriver is threaded into the end cap, and the end cap is removed with counterclockwise turns. To prevent rotation of the nail or displacement posteriorly, the extraction screw is threaded into the nail and tightened with the combination wrench prior to the removal of the locking screws. The hammer guide is attached to the extraction screw and tightened with the pin wrench. The T25 star drive screwdriver is used to remove the locking screws. The combined hammer is attached to the hammer guide, and the nail is extracted with gentle blows using the back slap technique. The instruments used for oblique proximal locking are the same as those used for proximal locking. For oblique locking, a cancellous bone locking screw, star drive, 5.0 mm diameter with dual core, self-tapping, is also needed. This screw is coloured gold. The gold colour of the screw corresponds to the yellow markings on the three-part trocar combination and drill bit, as well as the aiming arm. The gold cancellous bone locking screw is only used in combination with the two oblique proximal locking holes in the aiming arm, labelled oblique 1 and oblique 2, or the AP proximal locking hole. The aiming arm can be used to target all three oblique locking options. The oblique locking option labelled oblique 1 corresponds to the most proximal locking position. Inserting an end cap with this locking screw will create a fixed angle construct. This is the option demonstrated in this exercise. The three-part trocar combination is assembled and inserted through the hole in the aiming arm marked oblique 1 through a stab incision down to the surface of the bone. The trocar is removed. While ensuring that the drill sleeve is pressed firmly to the near cortex, a 3.2 mm hole is started. Drilling is stopped immediately upon penetrating the near cortex. Clinically, the position of the drill bit is monitored with image intensification. To do this, the image intensifier is oriented perpendicularly to the drill bit. The desired depth is drilled. A long cancellous bone locking screw will obtain better purchase in this cancellous bone. After drilling has been completed, the drill bit and drill sleeve are removed. While ensuring that the protection sleeve is pressed firmly to the bone, the measuring device is slid through it, making sure that the hook grasps the far cortex. The length of the screw is determined by reading the measurement at the back end of the protection sleeve, in this case 45 mm. The 5.0 cancellous bone locking screw is inserted through the protection sleeve and threaded into the hole with the screwdriver star drive T25, taking care not to over-tighten. Once the screw length has been verified, the screwdriver and protection sleeve are removed. End caps for the ETN are available in extension lengths of 0, 5, 10 and 15 mm. In this exercise, the 0 mm end cap will be inserted using the screwdriver star drive T40. The end caps are cannulated for use over a guide wire if necessary. End caps prevent bone growth into the nail, and they extend the nail height if it has been over-inserted. The screwdriver, hexagonal, 8.0 mm diameter, with spherical head and T-handle, is used to loosen the connecting screw so that it can be removed together with the insertion handle and the aiming arm. To prevent cross-threading, the end cap is inserted in line with the nail axis. A counterclockwise turn can be used to thread it in the nail before clockwise turns are used to advance it and secure it. Clinically, implant removal is an optional procedure. The instruments needed include the screwdriver, star drive T40 with spherical head, cannulated, length 330 mm. The extraction screw for tibial and femoral nails, the combination wrench, 11 mm diameter, the hammer guide, the pin wrench, 4.5 mm diameter, the screwdriver, star drive T25, self-holding, length 330 mm, and the combined hammer. The T40 star drive screwdriver is threaded into the end cap, and the end cap is removed with counterclockwise turns. The cancellous bone locking screw is removed with the T25 star drive screwdriver. To prevent rotation of the nail or displacement posteriorly, the extraction screw is threaded into the nail and tightened with the combination wrench prior to the removal of the locking screws. The hammer guide is attached to the extraction screw and tightened with the pin wrench. The T25 star drive screwdriver is used to remove the locking screws. The combined hammer is attached to the hammer guide, and the nail is extracted with gentle blows using the backslap technique. Dynamic compression locking requires the use of the connecting screw, cannulated, and the compression screw for Expert Tibial Nail. Dynamic compression locking can be used in situations of diastasis where primary compression or secondary controlled dynamization of the fracture gap is needed after nail insertion and can be accomplished without removing the insertion instruments. Compression locking allows for a maximum compression of 7 mm. If more compression of the fracture gap is needed, the conventional backslap technique is recommended. It should be noted that distal locking is required prior to compression locking. The three-part trocar combination is assembled and inserted through the hole marked Dynam on the aiming arm through a stab incision down to the surface of the bone. The trocar is removed. While ensuring that the drill sleeve is pressed firmly to the near cortex, a 3.2 mm hole is drilled through both cortices until the drill bit just penetrates the far cortex. The position of the drill bit is confirmed with image intensification. The drill bit is withdrawn and the drill sleeve is removed. While ensuring that the protection sleeve is pressed firmly to the bone, the measuring device is slid through it, making sure that the hook grasps the far cortex. The length of the first locking screw is read from the measuring device at the back end of the protection sleeve. The 4.0 locking screw is inserted through the protection sleeve and threaded into the hole with the screwdriver Star Drive T25. The screw length is verified under image intensification. The tip of the locking screw should not project more than 1 to 2 millimeters beyond the far cortex. After the length of the screw has been verified, the screwdriver and protection sleeve are removed. The compression screw is then inserted through the connecting screw and into the nail using the screwdriver hexagonal 8.0 mm diameter with spherical head and T-handle. As it is advanced, the compression screw will contact the dynamic locking screw, causing a reduction in the fracture gap. Each revolution of the screw corresponds to a compression of 1 mm, up to a maximum of 7 mm. Care is taken not to over-tighten the compression screw. After the required compression has been achieved, the compression screw is removed with counterclockwise turns. Using the hole marked Stat 1 in the aiming arm, the screw insertion sequence is repeated for the second proximal mediolateral locking screw. The screwdriver, hexagonal 8.0 mm diameter, with spherical head and T-handle, is used to loosen the connecting screw so that it can be removed together with the insertion handle and the aiming arm. The 0 mm end cap is inserted as described previously. Immediately after surgery, while the patient is still in the hospital, emphasis is given to pain control, mobilization, infection and deep venous thrombosis prophylaxis, and early recognition of complications. Occasionally, compartment syndrome develops after intramedullary nailing. Sensation and strength should be observed carefully the first day after nailing. Increasing pain may be a warning sign. The patient's leg should be slightly elevated, approximately 4 centimeters above the level of the heart. This maintains perfusion while helping to avoid swelling. As soon as the patient is able, partial weight-bearing with crutches is started. Unrestricted weight-bearing should be delayed until fracture callus is visible, fibular healing is evident, and weight-bearing is pain-free. You should now be able to state the clinical indications and contraindications, describe the correct patient positioning, identify the appropriate reduction techniques, recognize the surgical approach and entry point, and perform reamed intramedullary nailing using the ETN.